Okay, good evening, everyone. It's Rich here. Can everybody hear me? If just pop a quick message in the chat box, just so I know that you all hear me. Yep, lovely. That's fantastic. Welcome. This is the fifth lecture collaboration between BiteMedicine and GKT MSA. For those who haven't attended a webinar run by me before, my name is Rich. I'm an academic F1 doctor currently working in one of the Birmingham hospitals. And today's session is going to be on tachyarrhythmias and bradyarrhythmias. I'm very excited to give this session. This is something that I really struggled with at medical school and would have loved for it to have been laid bare for me. So hopefully this will be that opportunity for you guys. So before we begin, for those who aren't aware, BiteMedicine doesn't just do webinars. We also have our very own question bank that you can access through our website. There is a number of free quick cases that you can play around with, and if you like how it's set out, you can also upgrade to premium, and we currently have a 40% off discount, which is fantastic. So the way in which our question banks differs to some others is that it is a multi-step SBA, so case-based approach. So for example, you'll be given, as we can see here, Megan, a 24-year-old female, and we would work through all of her journey as a patient, all the way down to sort of complications of management and that sort of thing. And then to accompany this, you have an online textbook that we're constantly updating. We have every intention to get it fully kind of in line with the medical licensing assessment that's due to come out in a few years. So we're working very hard on updating this constantly. And this is our current webinar schedule for ECGs. So I'll be taking the next three, and the first one was delivered by Shoaib, one of our other co-founders, and can be found on our website. So I would encourage you to take a look back at those slides because the basics that were covered there will help us with today's session. This was relevant before our 40% off discount, but not so much at the moment. In the future, if you can't afford to go premium at the moment but want to, you can always use my discount code Richard2021. So yeah, this is a summary of today's session, and we'll be doing the same as normal, which is using Mentimeter. So if you type in menti.com and you put in this code, which I'll remind you about when we get to the questions later on, you'll be able to play along by submitting your own answers. And the session should last about 50 minutes. So thank you for those who have tuned in at 7 p.m. on a Wednesday. We greatly appreciate it. Okay. So a really brief recap. I don't want to spend too much time on this. This is something that Shoaib went through last week. So when we calculate heart rate on an ECG, one of the rules we use is 300 divided by the number of large squares between your RR interval. And if you remember, that's your upstroke on the QRS complex is the RR interval. We always comment on the rhythm of an ECG. So simply, is it regular or is it irregular? And Shoaib may or may not have mentioned the paper test that you can do, where you apply a sort of blank piece of paper along an ECG, you mark your QRS complexes on it, and then you shift it along the ECG, making sure your little marks always align, and that would show a regular rhythm. Axis, I believe, was covered as well. And in that case, your main leads that you look at to assess axis is leads 1 and AVF. P waves, you then go on to discuss P waves, and we'll be mentioning those today, particularly in relation to our tachycardias. So important to comment on morphology. So if they have these sort of double peaks, they might indicate hypertrophy of the right or left atrium. If it's absent altogether, it might indicate atrial fibrillation. If you see them as a sawtooth pattern, which will definitely be relevant later on, that could indicate flutter. And if they're dissociated, then it kind of implies that your P waves are no longer communicating, or so your atria is no longer communicating with your ventricles, and that would be cause for concern and could indicate heart block. So this is our QRS complex. So just familiarize yourself with the major regions because it will be relevant for today's session. So looking here, the PR interval is very important. If it becomes prolonged, that can be seen in AV block, essentially where our atria is not communicating with our ventricles. And if it's short, what that is essentially suggesting that there is a fast pathway, an additional fast pathway that is connecting our atria to our ventricles. So a short PR interval you should see in cases like Wolff-Parkinson-White, where you've got these additional pathways. And quite a specific feature of PR intervals, if you ever see it depressed, is in pericarditis. Now, these kind of things here go a bit beyond the scope of today's session, but I have every intention to cover them in future sessions. So just a bit of sort of facts for you there in terms of the timings. You'd usually get these reference ranges in the exam, but just good to commit to memory that 0.2 seconds is the upper limit of a normal PR interval. And then QRS itself, so if it's widened, that basically implies that in the case of a bundle branch block, that your ventricles are depolarizing for a longer period of time. So it's not a nice, neat biventricular depolarization. One is polarizing then the other, which would cause the QRS to be broader. And when it comes to tachycardias, as you'll see in today's session, commenting on broad versus narrow QRSs is absolutely essential to management. And finally, commenting on their amplitude is really important, as it can indicate essentially just too much ventricular muscle, which is why you therefore have more electrical activity. So I hope this is ringing some bells for those who attended last time. The QT interval, or the corrected QT interval here, is important to comment on, especially when it's long, as long QTs can sort of degrade into perius rest rhythms, particularly certain tachycardias. And there's a bunch of causes here, and we'll cover this again later, so I won't stress this point. And then finally, we've got the ST segment, so that's from the S on the QRS all the way to the T wave. You guys who've attended the acute coronary syndrome session by Schwabe, or have simply been on a ward, will know that the ST segment is really important when commenting on myocardial ischemia and is essential for ACS management. T waves, we won't be covering them today, but I plan to cover them in a future session, so I won't labor the point too much. And finally, there are some sort of classical features that you see on ECGs, like U waves, J waves, and delta waves, that are almost characteristic of these features here: hypokalemia, hypothermia, Wolff-Parkinson-White. And again, I plan to show you them in future sessions. So we've got lots to get through. I wanted to kick off directly with a question. So I'm going to what I'm going to do first is read you the question. Then I'm going to show you an ECG, at which point I'm then going to take you over to Menti, or invite you to go to Menti, and hopefully you'll still be able to see the ECG. So you can go to Menti now if you want to, menti.com, and the code for those who missed the beginning is, I'll type it in the chat, 40. Available. Yes, they're available on app.bitemedicine.com. You can download them right away. So if you head over to menti.com, so the first question, we're going to be asking the following: which of the following management options would be most correct for someone found collapsed with a pulse and the following ECG? Okay, so the options you should be able to see at menti.com. The options here are adenosine, amiodarone, atropine, magnesium sulfate, and synchronized DC cardioversion. So here is our ECG. Take a good look. I'll hide the answers for those playing along. So we wanted to know which of the following management options would be correct for someone found collapsed with a pulse and the following ECG. So I'll give you guys just a few more minutes to vote. Okay, so let's see what people have gone for. So majority have voted for synchronized DC cardioversion. Fantastic stuff. Yeah, that's absolutely right. So I'm delighted that we've kicked off with a strong start there. So if we head back to the slides, we can have a bit of a chat through why that is the correct thing to do. So first of all, just looking at this ECG, this, just looking at it, is a broad complex tachycardia. And now the reason this is right relates to this concept of adverse features, okay? So the patient had a broad complex tachyarrhythmia, and that would kind of lead you down a certain route of management. But because they had been found collapsed, that immediately indicates synchronized DC cardioversion, okay? None of the other options would be correct. So adenosine, that we'll approach later, is used to manage regular narrow complex tachyarrhythmias. Amiodarone is used for broad complex tachycardias that are regular, but usually when there are absent adverse features. But in this case, you would go for the DC cardioversion first. Atropine would not be appropriate for a tachycardia. This is for a bradyarrhythmia. And then magnesium sulfate could be used in certain broad complex tachycardias, but not in this case. So let's just kind of go through what it is we're talking about. So tachyarrhythmias, broadly speaking, is a heart rate above 100 beats per minute. How to manage. So I've come up with some basic steps that I think would be a sensible approach to take. So the first one is ask yourself, does the patient have a pulse? Very important. And sometimes when I've gone to the patient's bedside, I don't even think to do it, which is quite bad. So make sure you check, is this an arrest situation or are we in the peri-arrest situation? Cardiac arrest today is kind of going to go a bit beyond the scope of this lecture. I will briefly show you later on the sort of 4 major arrest rhythms that you should be aware of, but I'm not going to be going through the whole basic life support stuff. The next thing you need to be doing is, are there any adverse features? Do they have myocardial ischemia? Have they collapsed? Is there evidence of, inability to maintain their own cardiac output due to a shock? Have they got acute heart failure? Any of these, and you'd be really, really concerned, and the indication would be for synchronized DC cardioversion. So I've laid it out nice and clear here. You can give up to 3 shocks of this. And once you've done that, you can then consider starting them with a sort of fairly fast bolus of amiodarone 300 milligrams IV. So that is the management of any peri-arrest rhythm that shows adverse features. I want you guys to commit that to memory. Okay, so we're going to put that to bed straight away and then move on to step 3. So if they don't satisfy anything in step 2, then the next thing you need to do is go to town on their ECG and really start to look at their QRS and the rhythm. And for the QRS, you're looking, is it broad or narrow? And for the rhythm, you're looking, is it regular or irregular? And that will give you 4 possible outcomes, okay? A regular broad QRS, an irregular broad QRS, a regular narrow QRS, and an irregular narrow QRS. They all have different causes, and they all have different managements. And that roughly is going to be what we're talking about for today. So we're going to go through each one in turn and show you how they differ to one another and what we need to be doing for each, okay? So I hope that the format worked for question one, where we saw the ECG. So same question again, or very similar. Which of the following management options would be correct for someone with no adverse features and the following ECG? So again, the options are going to be adenosine, amiodarone, atropine, magnesium sulfate, and synchronized DC cardioversion. And our ECG is here. So I will just nip over to Menti. So question 2 should now be available, and I'll show you that ECG again so you guys can have a good old look. Those who are still asking for the Menti code, so it's 36403551. Okay, so we'll head over to Menti and see how you guys are getting on. So, fantastic. So, the majority wins again. Well done. Absolutely, amiodarone is the right thing to do here. So we'll head back over to our slides and see why. So again, this is a broad complex tachyarrhythmia. It's the exact same ECG as before, but the crucial difference here is there are no adverse features this time. So you've seen a regular broad complex tachyarrhythmia. The most likely explanation is ventricular tachycardia. We are going to address an exemption to that in a second. But if there were no adverse features, the appropriate thing to do would be to start amiodarone. And I would like to add that as an F1, I would not be doing this myself. At this point, I would be seeking help from either my medical registrar, or I'd be, on the blower to the cardio reg asking for help. So we've already gone through why these other drugs aren't really correct. So amiodarone, type 3 antiarrhythmic, blocks those outward potassium currents that are involved in the repolarization of the heart, thus slowing down the rate. So broad complex regular, most common would be VT. It could be that you've got an SVT, so supraventricular tachycardia, i.e. a tachycardia that is arising due to a problem anywhere above the level of the bundle of His, alongside a bundle branch block that would cause your QRS to be widened. I've put here that you might expect with someone like this that a previous ECG would show a bundle branch block, but if you were at all concerned, get in touch with your on-call cardiologist. So if you're thinking it's VT, how to manage? One, again, keep an eye out for those adverse features. There is a risk of decaying all the way to a cardiac arrest. 2, you can start amiodarone, 300 milligrams IV over 20 minutes. And after you've given that, you can start a 24-hour infusion, and that would be 900 milligrams. Okay. That is for broad complex regular tachyarrhythmias. So another question, this time slightly different. So we'll just set up the next question on Menti. So question here is, which of the following management options would be correct for someone with no adverse features and the following ECG? Our options are adenosine 6 milligrams IV, adenosine 12 milligrams IV, amiodarone 300 milligrams IV, 10% calcium gluconate 10 mil IV, or MagSulf 2 grams IV. And the ECG you're given is here. Okay, so take a good old look. We'll head over to you guys just a few more minutes to dissect this ECG. Okay. So let's see what you guys are going for. Okay, so we've got a bit more of a split here. So 6 of you going for calcium gluconate, 13 for mad sulf, some of you using amiodarone again. So let's have a look what the correct answer is. So this Menti seems to have frozen, unfortunately. So we'll go back to our main PowerPoint. We'll reveal the answer on there. So the answer is magnesium sulfate, absolutely. So this patient had a broad complex tachyarrhythmia with no adverse features, but this time it was irregular and polymorphic. So it was likely a polymorphic ventricular tachycardia, and therefore it needs to be managed with IV magnesium. So just going back to the ECG, if you were a bit unsure, so if you're looking at V2 here, you've definitely got kind of different morphologies of your QRS. And if you would be convinced there's slight differencing in the RR intervals, making it an irregular polymorphic VT. So magnesium sulfate is the appropriate thing to do here. For adenosine, this is inappropriate. These are used for regular narrow complex tachycardias, and amiodarone, as we've seen, is for our broad complex regular or just monomorphic VT. So just going through it in a little bit more detail. So causes of a broad complex irregular tachycardia would be torsade de pointes, or atrial fibrillation, which we all know is our kind of classic irregular ECG rhythm, plus a bundle branch block. So we're seeing this thing again where bundle branch block can cause wide QRSs, therefore it can make interpretation of these ECGs a little bit more difficult. So what is torsade de pointes? Well, it arises due to QT prolongation in most respects. And the way I was always taught it is, imagine the ECG trace dancing around the isoelectric line. So if you imagine that kind of the line where the electrical activity should be a flat line, you just sort of see these ups and downs going all over the place. And someone's just asked me privately, how does this differ to VF? Well, so the crucial difference here is VF is an arrest rhythm, and I'll show you guys that at the end of the session. So you would not expect the patient to have a pulse. So in this scenario, this patient had no adverse features, hence why you would assume this is polymorphic VT. So causes of a long QT. So you can be born with some funky genetic causes that can lead to long QT. Also, any sort of infarction of the muscle can damage the electrical conduction system, and again, leave you prone to all sorts of arrhythmias. Certain electrolyte imbalances, particularly low magnesium, calcium, and potassium, which is why it's so important as a junior doctor that if you recognize any hypo electrolytemias, that you treat them as soon as you can and appropriately. And then you've got your certain drugs that can cause long QT, and the way I always remember these is A, B, C, D, E. So anti-arrhythmics, antibiotics, antipsychotics for C, antidepressants, and antiemetics. And for those who are scribbling away, so some examples. So amiodarone can do it. Erythromycin would be an example of an antibiotic that could do it. Haloperidol, an example of an antipsychotic that could do it. Tricyclic antidepressants could do it. And I'm led to believe that ondansetron is an antiemetic that can do it. So A, B, C, D, E, I always thought that was quite a useful little learning tool to remember your causes of long QT. So features, you'd expect polymorphic VT, so different QRS morphologies. You might see QT prolongation. And as I've said already, you distinguish the difference between VF and this is the presence of a pulse. If you see it, I would contact your cardiologist. That would be my advice. So how to manage magnesium sulfate? All right. I think I've only seen one patient receive this in my sort of 8 to 10 months as a doctor, so I can't really comment on how common it is, but definitely one that as a junior you need to be able to watch out for. So I just thought I'd just put this in just for you guys to just take a quick break in case you needed to do anything, catch up with your notes, ask any questions, and then we can go onto the narrow complex side of things where it gets a bit more interesting. Just look in the chat. So someone asked that the ECG trace for question 1 and 2 was exactly the same. Please explain the difference in response. So the reason the answer was different was because in one case, in the question, the patient had adverse features, and in the second one, they didn't. So for adverse features in any tachyarrhythmia, we go for synchronized ECG vision. Okay, so now that was roughly 1 minute. So moving on, we go to, so I wanted to put this in. This is something that I just wanted to mention off the bat. So we will be talking about narrow, complex, regular, and irregular tachyarrhythmias. But before we started, I just wanted to mention this term, supraventricular tachycardia. So this is, you'll hear it bandied about as SVT. It describes any tachyarrhythmia that arises from above the level of the bundle of His. So I just thought it's important for you guys to know your terms. So some key examples. Atrial fibrillation would be an example of an SVT. So it's irregular, it's arising due to problems with the atria. Atrial flutter as well. And then your paroxysmal SVT, so these ones that kind of come and go. Classic examples being AVNRT, AVRT, and paroxysmal atrial tachycardia. Now these first 4 I hope to cover with you guys today, and hope to have made it a little bit more clear as to what they actually mean. So, question 4, we'll head back to Menti and hopefully it will have sorted itself out. Let's see. Yes, okay, good. So, question 4, which of the following management options would be correct for someone with no adverse features and the following ECG? And what I'm particularly looking for here is the first thing you should do. Okay, so give adenosine 6 milligrams only. Gives adenosine 6 followed by a further adenosine 6 milligrams if no effect. Adenosine 6 milligrams followed by up to 1 more 12 milligram adenosine dose. Adenosine 6 milligrams followed by up to 2 more 12 milligram adenosine doses, or vagal maneuvers. So those are your options, and you should be able to access them on Menti, so you can keep that open. And then let's have a look at this ECG. Okay, so hopefully that's enough time to have had a little look at that ECG. Now let's head over to what you guys are thinking. So, wow, pretty stark here. So 17 of you have gone for vagal maneuvers, and then you've sort of split roughly then across the other options. So let's have a look at what the answer is. Absolutely, this is vagal maneuvers. I'm delighted with that as an outcome. So really, really good job there, guys. So why is that correct? So this patient has a narrow, complex, regular tachycardia. And I'll just sort of show you why. So you look here, you look across this strip. Clearly, this patient is tachycardic, okay? It's a 10-second strip. Definitely, what are we talking? 1, 2, 3, 4, 5, 6. Definitely tachycardic. And also regular. And again, you can do that little trick with your piece of paper, compare it to a couple of hour intervals, and then move it along, making sure. Therefore, regardless of what's actually causing it, you can start with some vagal maneuvers, and we'll talk through what those actually are. The other options, they're incorrect because you should always start with vagal maneuvers unless there's a contraindication. And only this one here is the sort of the true correct reason. So adenosine 6 followed by up to 2 more 12 milligram adenosine doses is the thing you do after vagal maneuvers. But let's look at this in a bit more detail. So narrow complex regular tachycardias. So we've got our pathological causes like atrial flutter, AVNRT, and AVRT. But we've also got the most common one of all, which is sinus tachycardia, which everybody attending this webinar will have had at some point. So how to manage a pathological narrow complex regular tachycardia, I want to run through first. And then I also want to briefly mention actually how to spot a sinus tachycardia, because I think that's really important. And as an F1, it will be something that you're expected to be able to do, or at least have a go at before running to your cardiology registrar. But first things first, same again, look out for adverse features. If you found them, it would be back to basics. So synchronized DC cardioversion. Next thing up is vagal maneuvers. Now, the two ones they describe is one is a carotid massage. So essentially you stimulate vagal activity by activating your carotid baroreceptors, and that would act to sort of slow down the heart. But there is a bit of issue with that with certain patients, for example, those with atherosclerotic plaques in the carotids, where you could potentially dislodge something and cause a stroke. So it's always good to kind of auscultate the carotids first. Or you can get them to kind of initiate Valsalva maneuvers. And one of the classic things they do in ED is they just give them a syringe, and they have a little bit of air in it, and they just tell them to blow out and try and push the plunger out of the syringe. By doing that, you're sort of forced expiration against a closed airway, and that in theory should lower your heart rate somewhat and may help to reveal what type of tachycardia you've actually got going on. If that doesn't work, you can give adenosine 6 milligrams IV as a rapid bolus. I'm just going to the chat here. Does anybody know what you should warn your patient about before you give this drug? Very nice. Yes. Yeah. They will feel like they're dying, impending doom. Yes, exactly. A feeling of impending doom. I've seen this given twice. One time the patient just didn't even react, and the other time they looked, I mean, I didn't know a patient could actually turn gray, but they did. They looked really, really unwell. And it's really important that not only do you give it, but that you do a continuous ECG trace whilst you're giving it, because you want to see what that adenosine has done to their heart rate, and particularly has it uncovered any clues as to what ECG abnormality is going on. Has it revealed P waves or revealed kind of classic flutter waves? So give them the adenosine 6 milligrams IV. If that doesn't work, then you might need to give them 12 milligrams, and you can give that up to 2 times, and they're not going to like you after you've given the first 6 milligrams. They're really not going to like you the next time you give them 12. Now, it's important to say that if you don't get a response after any of this, this makes atrial flutter quite likely, okay? So you would expect with the paroxysmal SVTs like AVNRT and AVRT that you would get a response from these measures. So if you don't get any response, consider atrial flutter. So if you've got that in your your finals, in one of your SBA questions, and none of these measures have worked, and they ask which is the most likely, think, oh, this could potentially be atrial flutter. So let's have a bit of a chat about atrial flutter, AVNRT, AVRT, and most importantly, sinus tachycardia. So for those of you who have access to the slides, which should be available on app.bitemedicine.com, we produced a nice summary here. So this is being kind of adapted from the ALS algorithm, so how to manage a narrow complex tachycardia, but we've just summarized it on the previous slide. So starting with sinus tachycardia. So why do people get sinus tachycardia? Well, it can be, well, I mean, the reason I said we'd all had it is probably because at some point in our lives, we've all done exercise, I hope. And then there's a load of other reasons why you can get it. So it's seen in pulmonary embolisms, infection can drive it, people in pain, anxiety. So when you're the F1 on the ward and you're called to see these sinus tachy ECGs, just think to yourself, is the patient nervous? Like, can I kind of calm them down in any way? Are they in any pain that some simple regular paracetamol might help with? Am I concerned about a pulmonary embolism? Do I need to do, calculate a Wells score, do a D-dimer, that sort of thing? Are they on any offending drugs? Salbutamol inhalers can drive your heart rate up. Have they taken any recreational drugs? Caffeine is a classic one. So caffeine is an adenosine receptor antagonist. So it stands to reason that if you give adenosine to bring the heart rate down, if they've taken a load of caffeine that's blocking the adenosine receptor, your heart rate's going to go up. So those are the kind of classic causes. How to manage it? Well, make sure you recognize that it is sinus tachy, first of all, and there's no shame in getting someone to double check it. Absolutely no shame. And something that I was taught that that has proven to be somewhat helpful is this concept of the RP interval. So what the RP interval is, you look at the R wave and then the following P wave, okay? And you note that down as the RP interval. Next thing you do is you look at your PR interval, okay? So P to R. And if the RP interval is longer than the PR interval, that could be further evidence that this is a sinus tachycardia. Now, there are some pathological causes of long RP tachycardia. The reason I'd say it's important to do it is because if you have a short RP tachycardia, that would exclude sinus tachy. Okay, and we'll have a look later on at what a short RP tachycardia looks like. The reason I've included this is one of the cardiologists that I worked with on my previous job was quite particular about these, and I felt I'd honor him by including it in this PowerPoint. So just briefly then, you're the FY1 on call, you're asked to review someone with a raised heart rate, make sure you do your ECG, and then just think about these causes and think about how you might be able to exclude them by doing, taking a history, by examining, doing, serial ECGs, taking some basic bloods. All of these things are well within your remit. And, if you've done these 4 things, then if you turn to your SHO or you turn to your registrar and say, oh, look, can I have some help now? They'll be so happy because you've done a lot of the legwork already. But all I'd say is if you've got any concerns about an ECG, there's no shame in getting someone to look at it, because if you're worried, then you might be worried for a valid reason, and you might have ended up spotting something and potentially saving someone's life. So no shame in asking people to check. So that's sinus tachycardias. So let's talk about atrial flutter. So atrial flutter is another type of SVT, and it arises due to a re-entry circuit within the right atrium. So essentially this just sort of rotating electrical current that produces quite an organized electrical activity in the atrium of about 300 beats per minute. And the causes of atrial flutter, so some of you who know the atrial fibrillation revision quite well might have come across this mnemonic PIRATES for causes of atrial fibrillation, and the exact same mnemonic can be used for flutter. So PIRATES is pulmonary causes of atrial flutter or fibrillation, so either a PE or COPD can cause this circus rhythm. Ischemic heart disease, so again, anything that causes sort of infarction and scarring of tissue can disrupt your electrical activity and lead to all sorts of arrhythmias. Rheumatic heart disease, A's, advancing age is a really, really common one, but also alcohol and anemia. And it's not just alcohol at the time, but it's sort of as you're kind of coming out of the alcohol excess. So you might hear of something called holiday heart. So if you've done a week long in Ibiza, by the end of it, even when you're sat on the plane, your heart might be going into arrhythmias just because of the kind of the previous alcohol damage that you've done. Thyroid disease, so particularly raised thyroid levels, can cause fluttering and fibrillation of the heart. Electrolytes, so low magnesium and either low or high potassium are common offenders. So make sure that if you're concerned at all, you do these blood tests. And then S for sepsis and sleep apnea. So yeah, make sure you've committed this mnemonics to memory. Particularly this advancing age, I think this one is really important just to have ready if anyone ever asks you for why people get flutter and fibrillation. So some important facts to know: it's the second most common arrhythmia, so it's about 10 times less common than the most common one, which is AF, or atrial fibrillation. So the ventricular rate, so the actual thing that's going to determine your pulse rate, is determined by the atrioventricular conduction rate ratio, which is normally about 2:1. So this essentially means that your atria is firing at 300 beats per minute, but the communication that's actually getting to the ventricles and causing them to depolarize and contract is 150 beats per minute. So about every 2:1. Now that is not a pathological AV block. That is a physiological AV block. That is your heart being brilliant at what it does, that ensures that actually you're producing a ventricular rate that is compatible with life. And where you classically get this re-entry circuit is in your atrium, in the right atrium, usually between the inferior vena cava and the tricuspid isthmus, so that region. And that's important when it comes to considering things like where to ablate the heart during management. So looking at atrial flutter on an ECG, so for the keen-eyed among you, that previous ECG in that question was atrial flutter. So how to recognize it? You're going to see it on an ECG. So you would tend not to see sinus P waves. You would expect them to have tachycardia. So some key things to look for: you might expect to see this classic sawtooth pattern. And what that reflects is high amplitude P waves, which is representative of what that re-entry circuit in your right atrium is doing. The classic leads to look for them is leads 2, 3, and AVF, which is similar to your when you're looking for inferior STEMI, so 2, 3, AVF. And I'm sure if I could convince you here that there's these weird sort of sawtooth like squiggles on the ECG. Some advice is you're told to actually tip the ECG upside down when looking for flutter. And also, if you see a heart rate that is around 150, then that might sort of make you think, okay, I know exactly what's happening here. We've got atrial flutter going at 300 beats per minute, and it's got a 2:1 block resulting in a ventricular rate of 150. So make sure you flip your ECG upside down a bit like this, and you might convince you, if you look at AVF, a bit more classical sawtooth pattern here. So that is flutter. Now, how to manage it? I'm not going to cover that right away because it's very, very similar to atrial fibrillation. And in fact, I think there's only one area of the NICE CKS guidelines where it differs from fib to flutter. So we'll cover that slightly later on. But in terms of atrial flutter in the acute setting, do your vagal maneuvers and your adenosine, but it may not work. What it might do is slow the rate down just enough that it reveals that sawtooth pattern that gives you your diagnosis. As I said, we'll cover management later on. AVNRT, so this is where I would definitely drop your pencils and listen, because this is a little bit complicated, but if you follow along, should make sense. So atrioventricular nodal reentry tachycardia is the commonest SVT aside from atrial fibrillation and flutter. It's the commonest cause of palpitations in patients with structurally normal hearts, however. and is much more common in women than men. Unlike flutter, where we expect the tachycardia rate to be around 150, give or take, it's a much wider range there. So you can go from 140 all the way to 280 ventricular rate. And what's actually happening is you are getting a functional re-entry circuit. So there's no structural abnormalities as such, but you are getting a functional circus rhythm within the AV node that causes rapid firing and communication to the ventricles. And I'll show you on the next slide what I mean by that. And it's important to note that the way an AVNRT differs to an AVRT is that in AVRT, you actually have an anatomical circuit. So you have an additional pathway, a bit like in Wolff-Parkinson-White, that connects your atria to your ventricles. And we'll cover AVRT later on. So some causes of AVNRT are, massive exertion, certain drugs, anything that can basically cause your atrial or sinuatrial node to suddenly fire, sometimes out of sync. So like a preatrial complex, just out of sync of the normal atrial rate, that can then kick this circus rhythm into play. So let's have a look what I mean. And I spent quite a long time trying to make these squiggles. So I hope this helps you guys. So in a normal setting, here is your atrium, down here is your ventricle, and they're connected by the AV node. And there are two pathways, okay? You've got your fast pathway and your slow pathway. Now, normal conduction occurs down both, but the fast one gets there first. So it conducts the ventricles, and also a little bit of it tracks back, hits where the slow pathway is coming, and they cancel each other out, okay? And that's normal in our hearts, okay? If, however, you get a premature atrial complex in the atrias from things like exertion, drugs, spontaneous activity, then what happens is your fast pathway is still in its refractory phase. It has a much longer refractory phase. So your slow one has already recovered because of the way it works. And so instead of going down the fast pathway, it goes down the slow pathway. Okay, now your fast pathway is doing its best to recover. And as it recovers, you then start to get some activity coming down the fast pathway. That's what this blue line is. It's occurring slightly later. But the slow pathway has already made its way all the way down to the ventricles and started to track back round. But it cancels itself out when it meets the fast pathway. Okay, so no harm done. So instead of, on the left here, instead of going from the fast pathway to the ventricles, on the right, when you have a premature atrial complex, you go down your slow pathway because the fast pathway is still in its refractory phase until it recovers, at which point you get the fast pathway activation and the two meet and cancel. So what happens in a circus rhythm? Essentially, if your slow pathway conducts down to the ventricles and starts to make its way back round on the fast pathway before the anterograde fast pathway can even begin to conduct, you set up a circus rhythm, okay, which will then essentially just run around itself as fast as it can. And this will essentially lead to a rapid firing and a ventricular rate of anywhere between sort of 140 to 280. So I'll briefly go through that again. So on the left, we've got our fast pathway connecting atrium to ventricle and a slow pathway. And in normal settings, we have our anterograde conduction down the fast pathway and the slow pathway, and the fast one will cancel the slow one out here. We get a premature atrial complex occurring due to exertion or drugs, or just spontaneity, then your slow pathway is the one to conduct because your fast pathway is still in its refractory phase. And your slow pathway conducts to the ventricles and trucks back down retrograde, but in certain circumstances will be met by the recovering fast pathway and cancel out, no harm done. But in a scenario where your fast pathway has no anterograde conduction whatsoever, nothing of this blue line here, then you set up a circus rhythm that just rotates again and again and again. I'm happy to be emailed. I'll leave my email at the end of the slides if people want me to go through that a third time. But these slides and video will be uploaded onto our website a little bit later on. Okay. So this is for AVNRT. So how to recognize it? Well, again, you're not going to be expecting to see P waves if it's running really, really fast. If you can slow it down a bit, you might see P waves, and they're going to be all over the place. Okay, so you have to kind of go hunting with your magnifying glass, and some of the cardiologists are absolute wizards at finding these P waves. So they tend to be hidden within QRS complex or just after them, which is why you get this short RP interval. So for example, if you guys can see my mouse here over AVL, it might just be just after the QRS complex, you get a P wave because it's premature. It's not in keeping with how it should normally be. And as a result, you have a short RP interval. And you know, these cardiologists, they love all this stuff. But for you guys, it's kind of beyond the scope of what's expected, you know, at med school level. But the thing to remember is, you know, acutely, you manage it the same as for all pathological SVTs. So vagal maneuvers, adenosine. The good thing is it may resolve on its own, but if it is not, get some cardiology input. That is really, really important. Okay, and I've given another example here of where, so you can see a P wave here actually occurring after the QRS, before the T wave. And you know, you're not going to be expected to be able to recognize this, but the cardiologists might, and that's why they would use the term short RP interval. So that's AVNRT. Now let's have a think about AVRT, so atrioventricular reentry tachycardias. They're again a form of paroxysmal SVT. And in this case, what's happening is you've got an anatomical circuit that bypasses your AV node. So instead of going from the atria to the ventricles via this lovely bundle of His, you've got some different pathways, some different anatomical electrical sort of conduction system. And in the case of Wolff-Parkinson-White, which is the one we all think about, this accessory pathway is often called the bundle of Kent, okay? Different to the bundle of His. Now, in AVRT, what can happen is that you get this anterograde conduction down the bundle of Kent and then back on itself via the bundle of His or by some other accessory pathway. And it can lead to a circus rhythm being formed by this anatomical circuit. And this can lead to a sort of rapid circus rhythm that will cause the ventricles to depolarize and contract at a much faster rate than one would like, leading to a regular tachycardia. And this can occur both anterograde down the accessory pathway and then retrograde via the normal conduction system, but also the other way, okay? So in Wolff-Parkinson-White or in anyone with an additional ectopic conduction pathway, what we worry about is this anatomical circuit causing a circus rhythm leading to AVRT, okay? So if in your finals, you've got a patient with Wolff-Parkinson-White and they come in with tachycardia, it's probably likely that what they've got is an AVRT. So just briefly going over the differences there. So your AVNRT is functional, okay, formed within that AV node caused by exertion, drugs, whereas in your AVRT, you've got this anatomical pathway that exists on top of your normal conduction system and can lead to this circus rhythm occurring. So I hope that makes sense. As I say, I'll leave my email at the end and you can guys can email me. So which of the following management options would be correct for a previously fit 72-year-old female with no adverse features and the following new ECG finding. Okay, so this is brand new. There's an ECG a day ago that didn't show the following finding. So I'll just set up the next question on Menti, so you guys see that, and we'll just take you back to look at the ECG. So here's the ECG. Again, thinking about what Shoaib went through last time, rate, rhythm, important things to look at. Okay, so hopefully you've had long enough to look. So the options here were anticoagulation, bisoprolol, digoxin, refer to a cardiologist, or synchronized DC cardioversion. So what's the most appropriate thing to do? This 72-year-old female with no adverse features and the following new ECG. Let's see what you guys are going for. Okay, fantastic. Guys, you've absolutely slaughtered the quiz today. I'm really, really, really chuffed. I was a little bit worried about some of the question designs here, but well done. So let's talk through why this is the case. So this ECG is quite classical of atrial fibrillation with fast ventricular response. Okay, it's an irregular ECG, and it's very, very difficult to see any P waves here. So why is bisoprolol the correct thing to do? So first thing to say is anticoagulation. We hear AF and we often think, oh, they need to be on anticoagulation, but there are some specific rules, and it tends not to be indicated in new paroxysmal AF. If it's been there less than 48 hours, it's not the first thing we consider. If it persists, then yes, you would consider it. Given that they've got rapid ventricular response, you're going to want to rate limit them for the most part. And one of the first line options you should think about is bisoprolol. Digoxin is also an option, but you tend to use that as first line if there's an element of heart failure, because it has not only a negative chronotropic effect, but also a positive inotropic effect. So why do you rate control rather than rhythm control? Well, it's a bit of a gray area, and NICE are not super clear about it. But the important thing to say here is that for pharmacological and electrical cardioversion, so rhythm control, NICE state that you need cardiology referral, whereas rate control you wouldn't. And they also state that rate control tends to be needed even if you are going to do rhythm control. So bisoprolol is the most important thing to do. And I've left synchronized DC cardioversion in here as an option because I really, really want to hammer this home that you need to be looking for adverse features. So let's have a quick chat about irregular narrow complex tachycardias. So the most common cause for narrow complex irregular rhythm would be atrial fibrillation. You also have to think, could this be atrial flutter with variable block? Okay, that's just for you a kind of top decile thought out there that we don't have really time to consider today. So key facts about atrial fibrillation and how it differs to flutter. So unlike flutter, where it's this organized sort of rhythm in the right atrium, atrial fibrillation is chaotic, irregular electrical activity, usually in the left atrium, okay, that causes the atria to sort of fibrillate like this. And what can happen is that can generate sort of prothrombotic environment, which is why we really worry about stroke risk in atrial fibrillation. So your regular physiological impulses by the SA node are overwhelmed by this presence of electrical discharge in atrial fibrillation. And we've just said we worry about stroke risk due to clot formation. So it's really important to calculate the CHADS-VASc score. And we have a fantastic textbook entry on atrial fibrillation and anticoagulation on our website, which I would love to direct you guys to after this session. Again, I'm not going to go through them all again, but it's the same. So causes of atrial flutter and atrial fibrillation, they're very, very similar. So some things to consider there, and quite a lot of these are sort of reversible causes. So PE you could potentially reverse, electrolytes you can definitely reverse, hyperthyroidism. So definitely some things to think about when exploring why somebody's got atrial fibrillation. And here it is there, just an irregular rhythm with no P waves. So management, this was taken from one of Azim's previous webinars on AF. So first thing you have to ask yourself is how long have they had the AF? If it's less than 48 hours, then think about rate or rhythm control, and we'll have a little look about you know, which one you would go for. But we felt that in this case, this woman would benefit first of all from rate control. If they've had atrial fibrillation for more than 48 hours, or it's unclear why they've had it, then it's recommended that you go for rate control as well as anticoagulation for a minimum of 3 weeks. So your anticoagulation options being some form of oral anticoagulation like warfarin, or one of the newer direct oral anticoagulation, Pixaban. And then you may want to consider rhythm control depending on patient preference or certain patient factors. Again, drumming it in, presence of adverse features, go for electrical cardioversion. So these are some things that I plucked from a nice website. So if a patient is younger than 65 years, it's assumed that they will respond better to rhythm control than someone who's over 65 who's given rhythm control. If they've got a reversible cause as well, sometimes it's patient preference. Some patients will really, really hate the feeling of having an irregular pulse and may be very, very aware of their own heartbeat, which is what we refer to as palpitations. There's a little list here that you guys can refer to as to reasons why someone might go for rhythm control, but it's not a kind of cut and dry case for when we give it. And as I've said previously, it does require cardiology referral. So just going through them in terms of some classic kind of high yield information for your exams. So rate control, think about beta blockers like bisoprolol, calcium channel blockers like verapamil and digoxin. If in your SBAs your patient has asthma, they're usually testing to see whether you know not to give a beta blocker. Okay, so they're relatively contraindicated in asthma. For verapamil, tend to avoid them in heart failure. And for digoxin, they tend to be indicated in heart failure because, as I said, they've got that positive inotropic effect. Second line then, so if you haven't managed to get on top of their rate with one of these agents, then you may consider either digoxin and bisoprolol together, or digoxin and a different calcium channel blocker called diltiazem. So these are examples of non-dihydropyridine calcium channel blockers, okay, with your DHP ones being things like amlodipine. They're not relevant here. Looking at rhythm control, so as we said, refer to a cardiologist if that's what you're thinking of doing. In addition, so the rhythm control is given in addition to the rate control. And some examples might be amiodarone or flecainide. So flecainide being a type 1 antiarrhythmic, amiodarone being a type 3. And you've also got your option of electrical. So you can actually give, kind of gently sedate the patient, either take them into a side room or into theatre and have the cardiologist give them synchronized DC cardioversion. And ablation is also an option. So I was having a chat with a cardiologist the other day about ablation, and if we're thinking about ablation being indicated for flutter and fibrillation, because we said flutter occurs more in the right atrium, during that ablative process, you might have little bits kind of ping off the side of the wall. In flutter, where it's occurring in the right atrium, there is a slightly increased risk of pulmonary embolism because it's going to go into the right ventricle and off into your lungs. Whereas in atrial fibrillation, where it's a left atrial predominantly, the ablative process might increase your risk of stroke. So those are some things that you would kind of go through with the patient during consent. So we've pretty much reached the end for tachyarrhythmias. So this is kind of a summary slide that you guys can kind of take away and refer to. So for the broad QRS, we talked about ventricular tachycardia and also SVT with bundle branch block. And your main things that you're going to be giving here are IV amiodarone, firstly 300, then 900. For broad QRS irregular, thinking torsade de pointe and polymorphic VT, secondary to long QT. So think about your causes of long QT, like your drugs and your congenital causes. The key thing here is to give IV magnesium sulfate. So for the narrow QRS, so this was where we spent most of our discussion today. So think about atrial flutter, AVNRT, which was our functional circus rhythm, or AVRT, which was our anatomical rhythm. So start with vagal maneuvers, then trial a 6 milligram adenosine bolus, making sure to specify that they may have a feeling of impending doom, followed by 2 more 12 milligram boluses. And finally, your irregular narrow QRS, the most common thing being atrial fibrillation. In the case of being less than 48 hours, consider rate or rhythm control. More than 48 hours, you give a rate control and anticoagulation. So before we briefly touch upon bradyarrhythmias, which will take no longer than 5 minutes, I also just wanted to touch upon some arrest rhythms with you guys. On the left here, we've got a broad complex tachycardia. So without a pulse, that would make this pulseless VT. Okay, and beneath it here, we've got completely disorganized electrical activity without a pulse, which is classically VF. Now, these are our shockable rhythms. Moving over to the right-hand side of the screen, we've got pulseless electrical activity, which is essentially lovely looking ECG, but for some reason, the patient's got no cardiac output and no pulse. And then down here, the other non-shockable rhythm is asystole, which is an almost flat line. Never say flat line, it slightly deviates, as you can see here, and that's due to absolutely zero electrical activity in the heart, or very little. So that's the arrest rhythms. So finally, just briefly touching on the bradyarrhythmias, and my intention is in the next session is to go through AV block and bundle branch block in some more detail. I won't be kind of hammering the points home today because I realize we've almost hit our sort of end of the session. So with bradyarrhythmias, it's important to identify, have you got a regular rhythm or an irregular rhythm? First thing to say is a lot of patients might come to you with bradycardia, and these often tend to just be very fit athletes, okay? But what you have to be careful for is whether or not this patient's pulse is, physiological due to them being fit, or if they've got some horrendous AV block occurring, okay? Which is where in third degree, your atria and ventricles are just not talking at all. And so your pulse is purely dependent upon your ventricular pacemaker, which we all have, and is kind of a backup measure to your normal conduction system. So causes of bradycardia that can kind of lead to these different presentations. So physiological bradycardia, again, ischemia is always going to be correct when it comes to the heart. So infarction and scarring of the conduction system. It might be congenital. It could be due to electrolytes. We saw earlier that hyperthyroidism tended to cause tachycardia, whereas in this case, hypothyroidism would cause bradycardia. And the kind of final thing I want to leave you with in relation to bradyarrhythmias is kind of the broad management of them. So first thing you want to do is, again, look, are there any adverse features? Now, in this case, if there are, then you go straight to the atropine. So for those who remember, atropine is a muscarinic M2 antagonist. So it's going to block that vagal activity on the heart, which is going to allow the heart to beat slightly faster. If you get no satisfactory response, then you can try some more atropine, or you can try some different drugs such as isoprenaline or adrenaline, or you may even need to start with some pacing, so basically putting some wires on the patient and then manually stimulating their heart, which can be pretty unpleasant. Again, these are all going to be things that you're going to be kind of asking your registrar to assist you with, and at some point the cardiologist will step in and help. Down the kind of other side of the algorithm, then, if there are no adverse features, then you need to identify, are they at risk of decaying into an arrest rhythm, so asystole. The way to assess this is, have they previously had asystole? Do they have evidence of a AV block of Mobitz type 2 or higher? So the Mobitz classification we'll touch upon next time, but essentially is where your PR interval is prolonged, and then occasionally you just have a P wave that fails to conduct into a QRS complex at all. So that's a Mobitz type 2 AV block. You may also have a complete heart block as well. So anything like these, plus a recent asystole, would be cause for concern and would direct you down to these interim measures, such as we've said, atropine, isoprenaline, transcutaneous pacing. If they don't have any of these features, then stick them on a monitor and observe them. So they should have a slightly higher kind of nursing care, so potentially, you know, don't stick them in a bay where a nurse is looking after 6 to 8 patients. So that is bradyarrhythmias, and as I say, it's kind of beyond the scope of today's session, so I hope to be able to go through AV block in a bit more detail next time. So a whole host of references there for you guys to kind of dissect through, should you wish. And then kind of my parting words would be, the more ECGs you review, the better you will get. It's nice and simple. So thanks very much. Hope you enjoyed. Happy to answer any questions. You can email us, you can DM us on Instagram. I'm happy to be emailed myself. I'll put my email in the chat should you want to. Yeah, thanks very much for coming on a Wednesday night. I really, really appreciate it. So someone's asked about causes of a pulseless electrical activity. So essentially, some structural things, Sarah. So, you know, if you've got completely reduced cardiac output due to sort of obstruction, then that could lead to normal electrical conduction, but no output. Brilliant. Thank you, guys. Yeah, please do ask any questions. Slides are available, app.bitemedicine.com. The upload for this kind of recording will go up in the next few days. Our team are kind of working around the clock and also have their clinical responsibilities to juggle as well. So apologies if we don't get that up before the end of the week. Thank you, guys. I'll just have a look through the questions that were submitted. So someone's asked which arrhythmias are shockable and non-shockable. So it was VF and pulseless VT are the shockable rhythms. Evidence shows that they're the ones that will respond to unsynchronized DC cardioversion, and the non-shockable ones have been shown not to. Yeah, we'll be doing another session in about 2 weeks on AV block and bundle branch block, and then we'll finally finish up with some sort of spot diagnosis ECGs. I hope to have a few more questions at that session on Menti.com. I know you guys enjoy that stuff. And hopefully by the end of that kind of 4 or 5 session ECG series that we've done, you'll all be, you know, complete pros at ECGs, and you'll be you'll make fantastic doctors and physician associates. Okay, guys. if you have any more questions, please email me. I'll just stick my email in the chat. I'm going to be logging off shortly. So thank you very much. And yeah, just a reminder that we do have a 40% discount code currently running for the week. So do please check that out for all of our premium content. Smashing. Okay, hope to see you guys soon. Have a fantastic rest of your week and please stay safe. Okay, bye-bye.